Hello, welcome back to the second session of today's programme. I need to give apologies. I think there was a delay in the poster video starting. There was a technical hitch there, so we're going to try to get the video played again during the lunch break, but all of the poster presentations are available on demand via the website link anyway. So our next session is a really interesting topic. Legislation is such an important area for mental health and also an area fraught with challenges. As an inpatient consultant, I see these complexities and challenges day to day. And the area has become even more interesting given the changes proposed during the COVID pandemic, which fortunately weren't enacted. But with mental health legislation, we're really talking about the crux of what is a mental disorder and at what stage does a person lose capacity to make decisions about treatment. And for me, I think the more I think about mental health legislation, the more questions arise, such as what is best interests for a patient? Is it ever okay to override a person's autonomy? And is it okay to deny someone a treatment because they're too unwell to consent? So the topic really does encompass major ethical, social and medical dilemmas. So I'm very pleased to present our speakers today. Jill Stavert is Professor of Mental Health and Capacity Law at Napier University. Areas of expertise include international, European and national human rights and mental health law. At Napier, Prof. Stavert leads the Multidisciplinary Centre for Mental Health Practice, Policy and Law Research. She's a member of the executive of the Scott Review and was an expert advisor to the recent independent review on learning disability and autism in the Mental Health Act. Professor Colin McKay is Professor of Mental Health and Capacity Law at Napier University. He's a member of the Mental Health and Disability Committee of the Law Society of Scotland. From 2014 to 2020, Prof. McKay was Chief Executive of the Mental Welfare Commission for Scotland. He has extensive experience as a civil servant, including in the fields of justice, strategy and public service reform, initially training as a solicitor. So thank you very both for joining us today. I'll hand over in a second just to remind the audience, those attending virtually, that you can ask questions through the chat and then we'll try and get to those at the end. Thank you.
Thanks very much, Ashley. Thank you very much for inviting us to speak today. We're going to be talking about potential research that might arise or we might want to know about in connection with the Mental Health Law Review in Scotland. First, a little bit about the review, and then we'll talk about the different work streams. The principal aim of the Scott Review is to improve the rights and protections of persons with mental disorder and to remove barriers to those caring for their health and welfare. The review was established in May 2019 and it's chaired by John Scott QC. It's looking at the Mental Health Act, but also the Adults with Incapacity Act and Adult Support Protection legislation, and follows on from the recent Learning Disability and Autism Review and also the Scottish Government work on reform of the Adults with Incapacity Act. And what's important about the review is that there is a strong lived experience component in the review. In terms of the executive team, which Colin and I are members of, and also the advisory groups for the review, and and we also have a lived experience reference group. There's 50% membership in all the various groups and in the executive team. Why this review? Well, the existing legislation, despite its human rights and patient-centred and person-centred aspirations, hasn't been meeting the spot, or that's what we've been hearing. And it hasn't been fully meeting the needs of people with mental health and mental capacity issues in Scotland and their families. And also, there is a feeling that the person's voice is being lost in the process where decisions are being made for that purpose. What's also happened since the legislation was enacted is that the UK ratified the UN Convention on the Rights of Persons with Disabilities, which has brought a real shift in approach to the rights of persons with mental disabilities. And by that, I mean to include people with mental disorder as defined under our legislation in Scotland. And this treaty is very likely to be incorporated into our law in Scotland in due course. And the central message of the Convention on the Rights of Persons with Disabilities is that persons with mental health and mental capacity issues are entitled to enjoy all rights, that means civil, political, economic, social and cultural rights, on an equal basis with everybody else. But it might be that a little bit of extra support is needed in order to achieve that. And that diagnosis and related impairments, such as decision-making challenges, should not be used to justify any limitation or denial of those rights, so that the person's ability to exercise their autonomy and fully participate in society and obtain support is impacted simply because by virtue of a diagnosis or impairment. So that what that basically means is giving effect to the needs and the related rights that are wider than merely care and treatment, and also considering alternatives to coercion, and to put in place a range of measures to ensure that a person's voice is heard at all times, even when decisions are being made for them. The review will report next autumn, in autumn 2022. We don't know what's definitely going to be in the report, but it will contain recommendations for changes in the existing law, and most likely the environment in which those changes must take place. And also what improvements can be implemented prior to that law change, because there's probably quite a lot that can happen with the existing law that doesn't actually require legislative change. And also it will highlight, we hope, the research that it will be needed to support any changes going forward, to provide a robust evidence evidence base for that. As I say, we can't exactly say what's going to be in the report in terms of research, but what we'd like to know now is whether there's any research out there that could support our final recommendations next autumn, and also to discuss what might be supportive of the review and its recommendations going forward to provide that evidence base. So what we're going to talk about now as the work of some of the works, all the work streams and the reference groups provide a sort of update of where we are in terms of what we know in terms of the existing evidence base and what we need to know. And I'll hand over to Colin to talk about the first few work streams.
Thanks very much, Jill, and good afternoon, everybody. The first work stream I'd like to talk about is the compulsion work stream, and of course compulsion is at the heart of mental health law and indeed incapacity law. And these are some of the things we broadly know at the moment around compulsion. A lot of the information we have about this is through data collected by the Mental Welfare Commission. Just to say a little bit about the policy context and what we're looking at in the review. Obviously, one of the things that is core really to what we're looking at is the Convention on the Rights of Persons with Disabilities. And there's a very strong commitment, certainly by the UN committee that supports the Convention and a lot of people around them, to an approach which would effectively end compulsion as we know it. I mean, the UN committee have taken a fairly radical stance around what the meaning of the convention is, and that what that implies is that essentially mental health law and capacity law, as we understand it, needs to end. So there's been a big debate in the review and a lot of discussion with stakeholders about, can we actually end involuntary treatment in the review? And that debate's going on and will go on over the next 9 months or so. A quick spoiler alert is the answer is probably not, or it's probably not right now. And even people we've spoken to, international experts, who are actually very supportive of the committee's approach, accept that no country in the world has yet, as it were, abolished compulsion, although some countries have done a lot to move away from the old paradigm, as it were. But I think one of the things we are clear about is that there's a lot that we need to do to make a systematic shift to reduce coercion in mental health care and get as far as we can on eliminating coercion in mental health care. And that this is a journey that will take place over a decade at least. We don't know quite whether we'll get to the end point, and we can't quite see what the end point will look like, but we do need to make systematic and significant steps on a journey towards reducing and eliminating coercion in mental health services. Now, the current data we have tells us something about the numbers, but it focuses very much on, as it were, the point at which involuntary treatment is authorised. So the Commission data will tell you about how many people are on a compulsory treatment order, how many people are on short-term detention, how many people are subject to guardianship under the Adults with Incapacity Act, and although the data is a lot softer, how often the police use emergency powers to take people to a place of safety. And there's a constant story and a consistent story of the rising use of both the Mental Health Act and the Adults with Incapacity Act over the past 20 years, especially but not only around older people, and that may be partly explained by demographic shifts, and also younger people, but it's across the board. But what that data doesn't tell us a lot about is what happens to people after compulsion. And I think when we focus on the kind of idea of coercion, it isn't just, as it were, the fact of detention or the fact that a guardian has been appointed. When we've spoken to people with lived experience, often they've said, well, you know, I didn't like it at the time, but I recognise in retrospect that perhaps I did need to be in hospital during a period of crisis. But what happened to me when I was there was awful and traumatic. And so we don't know as much about the highly coercive interventions that are authorised by detention and the Mental Health Act. So the use of physical restraint, the use of seclusion and isolation, forcible medication, and so on. And I think we need to get a handle on those if we're to make any mileage in reducing coercive practice in mental health care. And that's one of the, I mean, we do like to generally kind of pat ourselves on the back and say we're much better than England, but that's one of the areas, particularly after, for example, Semi's law in England, where they have actually committed to a greater degree of monitoring of things like physical restraint in mental health services. So here are some of the things that we'd like to know now and we will need to know in the future. One is that the Commission data has always highlighted a huge variation across the country in the use of compulsory interventions, and it's not all explainable by rurality versus urban centres, poverty and so on. I mean, we don't have good data on why it is that some places that are similar to other places end up detaining a lot more people. And that's important because it already links to quality indicators. One of the quality indicators, I think, in the current mental health system is that fewer emergency detentions is assumed to be a good thing because it's an indicator that you have better community services that are stopping people reaching crisis. Now, that may be true, but there may be other reasons. I mean, I remember when I was at the Commission having a conversation with one health board who had quite a high number of emergency detentions, and they said, well, we're actually quite proud of that because what we're doing is stopping people from completing suicide, and we think we would be less successful if we didn't use the powers that we had. So we need to understand more about that. But if we are committed to reducing coercive practice more generally, we need to know much more about how you do that, how you prevent compulsion or coercion, how you minimise the use of coercion, and how you ensure it's not repeated. And a lot of that has to go back before the point of detention. When I worked at the Commission and we used to visit hospitals, you know, I'm not a clinician, and so I'm not qualified to say, but I didn't meet that many people where I couldn't understand why they were detained at the time they were detained. But if you go back into the history, and people who are clinicians will say this as well, you could see points at which an intervention might have taken place that might have prevented the situation getting as bad as it got. So we need to think no more about what would be effective earlier interventions that would reduce the need for compulsion or the use of coercion. And certainly we need to be more systematic around issues like the use of restraint, around the follow-up to that, around how we minimise it and how we stop it from being used again. And that's one of the areas where I think there's been work done on that, and the Healthcare Improvement Scotland and the Patient Safety Programme did work, for example, on reducing restraint. And it was, it was good work, and it did highlight a lot of useful experiments and innovations. But my sense is it was never systematically followed up. It was kind of one of these sort of coalitions of the willing, that wards who want to do this could sign up for the programme and do it. But there wasn't a sense that this has to be rolled out consistently across the health service. And we do think that these things will take a long intervention over a period of time. There's also something about a culture of innovation. When we speak to people like the WHO about ending compulsion and coercion, what they'll say is, well, you need to look at this service in Germany, and you need to look at the service in Trieste in Italy. Look at what they've done. They've managed to reduce the use of compulsory detention and coercive interventions. And we are speaking to them, and we are looking at what evidence there is. What I suppose we haven't seen to date, this may be unfair, is the kind of innovations in Scotland that perhaps 30 or 40 years ago Scotland was known for in terms of innovative psychiatric practice. And I think there's a question for us about, how do we change that culture so there can be more innovation around reducing compulsion and coercion, but how can there also be systematic evaluation and rollout of successful ways of reducing coercion and developing alternatives to compulsory admission. One of the areas particularly is around crisis response. We've had a lot of evidence from people who say, yes, I was in a crisis, yes, I needed to go somewhere. Where I didn't need to go was an acute admissions ward, which I found more traumatic than it needed to be. Say a little bit about children and young people. Kind of a similar story. Detention is rising. We know a lot about service gaps, and there's been a lot of work in children and young people services to develop new service specifications, and there does seem to be a consensus that the service model needs to change. There is, though, a bit of a disconnect in our view between the mental health system and the CAMS system and the use of the Mental Health Act and the wider service reform that's going on in children's services through things like the Promise, through the implementation of the UN Convention on the Rights of the Child, and so on. And one of the sort of hypotheses we have, which may need testing and challenging, is that there are people with mental illness or mental disability across these systems in the care system. Lots of care experienced young people have mental health problems, certainly in the system around additional support needs. And people in the mental health system also have care needs, family needs, educational needs, and so on. So a big question for us is, are these actually the same kind of people and children and young people who are falling into different bits of the system? And where they end up is more determined by the person who happens to see them than by any fundamental distinction in their needs. There are obviously massive societal questions about the level of mental distress around young people and some of the subcategories of that, around issues around gender identity, issues around neurodiversity, and so on. We're also looking at formal interventions. One of the big questions we have is whether we should be integrating the judicial oversight of formal interventions such as secure care, such as psychiatric care across the system, and what would that look like? Another big issue for us around children and young people is that the Mental Health Act is essentially the same for children as it is for adults. But we do know that children may be more affected by particular interventions. For example, their sense of time may be different. So, a 24-hour intervention in the life of a child may be substantially more traumatic than a 24-hour intervention in the life of an adult. So we may need additional safeguards for children, and we want to think that through. And we certainly know that children and families don't always feel empowered when they're in contact with the system. But last one I'll talk about is economic, social and cultural rights. What I put up on the slide is essentially the prospectus from the Human Rights Task Force that was looking at how we incorporate international human rights into domestic law and what they say that needs. So whatever we say in our report, these are things that if we incorporate the ICESCR and the UNCRPD, we will have to do. And the rights include the maximum right to physical and mental health, rights to independent living. And you'll see that data plays a big part in this because we need minimum obligations, we need monitoring, and we need accountability across the system. And we can't do that without data. And it goes wider than data on compulsory interventions. We need to look at the impact of housing, for example, impact of welfare benefits. We need to know if interventions are actually shifting the dial in terms of outcomes. And so we don't just create inflexible entitlements, but we actually do something that meaningful impacts on people's rights. We need a lot more data on intersectionality. We've got very poor data on BME people with mental health needs, for example. And the CRPD is clear that disabled people's organisations need to play a meaningful role in policy development, that they're not just stakeholders. So there's a whole lot of things we need to know, going wider than, as I say, the use of the Mental Health Act. And that requires a research agenda which will need to be sustained over years and will need strategic funding. And I hope that's one of the things we can think about going forward. I'll hand you back to Jill.
Thanks, Colin. So fundamentally, we have to also decide what sort of triggers there should be under our legislation for support and protection of people with mental health and mental capacity issues that are also human rights observant. And at the moment, we've been drafting and sort of working up an assessment framework as an alternative to the one that's already there, which is basically a capacity under the Adults with Incapacity Act, or a SIDMA, so significantly impaired decision-making ability assessment under the mental health legislation. It's very much a work in progress at the moment, but what we're proposing and are seeking feedback from experts groups at the moment, and then we'll be going out to wider consultation next year, are basically a human rights assessment and supported decision-making regime that run at all times, and irrespective of whether somebody's been assessed as having capacity or incapacity, so that, to ensure that a person's needs are actually met and that the accompanying rights are also respected at the same time, and that the person's voice is kept alive throughout the whole process, even when decisions have been taken for that person on their behalf. But the feedback we were also getting from the advisory groups and generally from consultation to date by the review is that we do need some sort of trigger to authorise non-consensual interventions when it's absolutely necessary for that to happen. And there's been a lot of appetite to actually retain capacity or SIDMA assessments alongside this, but perhaps not as a first resort, but as a last resort. So we are fitting that within the assessment framework at the moment. Whether it's actually called a capacity or a SIDMA assessment remains to be seen, but there's obviously a lot of work to be done there. What we do know is that we are struggling with the feeling, or the concern of the UN Committee on the Rights of Persons with Disabilities, which is highly suspicious of capacity assessments because it feels that these are stigmatising. They make all sorts of assumptions about a person's abilities and risk, and therefore, if someone is assessed as lacking capacity, and therefore proxy decisions are made about them, about their care and treatment, and about their life generally, then that's not compatible with equal enjoyment of rights and is discriminatory. From a survey we carried out as part of the review, and also just general feedback we've received through the advisory groups, it is clear that currently capacity and SIDMA assessments leave much to be desired. There's a lack of uniformity. They seem to vary from person to person, from assessor to assessor. They're sometimes used by practitioners to obtain support and protection for an individual, not because necessarily a capacity or a SIDMA assessment is correct, but in those circumstances, but simply to get the support and protection that that person needs. There are also situations where somebody is assessed as having capacity, but is clearly distressed, and they're left without any support and protection under those circumstances. We hear a lot of distress arising from those situations too. But at the same time, we're wondering how we can operate capacity and SIDMA assessments without being discriminatory, given at the moment they're actually very much attached to mental disorder. Can we make them disability and diagnosis neutral? Is that possible? Is it appropriate? The other thing that we are working on, as I said, is a supported decision-making framework. And that would, as I said, will transcend any sort of capacity or SIDMA assessment, so that somebody's will and preferences are kept alive at all times, even if they're not able to express that at that particular time. So it would be through things such as peer support, advocacy, advanced planning, including advanced statements. But we're still not entirely sure how that's actually going to work in practice in all cases. And there's a dearth of research in different forms of supported decision-making, how they operate, and the outcomes that they achieve, what sort of outcomes and whose outcomes do they achieve. We're particularly interested in advanced planning, including advanced statements. But we also want to tackle the issue of how do we keep the wishes and feelings expressed, or the will and preferences expressed in advanced statements, up to date, alive, so that they're actually what the person definitely wants at that particular time. So that because at the moment they're triggered by incapacity assessments, and somebody might be locked into historic decisions which no longer are applicable to that person and the way that they're living and what they want at that particular time. So what are we wanting to know? Well, at the moment, we really would like to know how human rights assessments, which are a fairly new idea, they've been used in various sort of benefit welfare situations in England and Wales, and they were suggested by the Essex Autonomy Project 3 jurisdictions reports, which I had the privilege of being part of the research team for that project, as being an alternative way of approaching things. But how do they work in practice? How effective will they be? How do they fit in so that they're not a burden, they're just complementing good practice at the moment? Because we realise that adding another layer of complexity and bureaucracy to busy professionals' lives will not be welcomed if they're to be effective. As I said, supported decision-making, we need to know what works, what's available now and how's that working, but also going forward, other forms of support. And also whether they can definitely operate outside of capacity assessments. As well, we need to know about how we can improve capacity and SIDMA assessments. If we do keep these as a form of assessment, do we just have a capacity assessment or an incapacity assessment, which is actually creates parity between physical and mental health situations? Do we include aspects of SIDMA into the capacity assessment, or do we keep them separate for adults with incapacity situations, wider situations, and have a specific decision-making, a SIDMA assessment in the case of psychiatric care and treatment? And as I said, can they ever be non-discriminatory? Actually, do they have to be discriminatory given the particular conditions concerned? In terms of adults with incapacity, we have a working group on that at the moment. What we do know now is that guardianship is not fit for purpose, and there are CRPD committee concerns about guardianship. In fact, the committee, along with saying that forced psychiatric treatment should be abolished, has also said that guardianship and the equivalent should be abolished too, again, because they don't provide enough scope for the individual's voice to be heard and to drive decisions about that person, that allows the guardian to make decisions for that person, irrespective of what that person says or feels at the time, or has indicated before. We're suggesting a decision-making framework, which is rather like a sort of graded guardianship system. But again, we want feedback on that, and whether actually we have to stick with an enhanced guardianship system or go with a new decision-making framework, which fits much more into the assessment framework I mentioned before. And along with that are all the capacity and supported decision-making issues that I mentioned before. The other thing that we're having to resolve is the issue of deprivation of liberty for persons who are unable to consent to a deprivation of liberty in health and social care situations. Colin mentioned before that we tend to feel that we do things rather better in Scotland than happens in England, and it's true to say we perhaps haven't had the trouble that England has had with the deprivation of liberty safeguards there. But that's probably because we haven't actually done anything about the deprivation of liberty situation in Scotland, so we can't make a mistake with those. This is an issue that's been hanging around since the European Court of Human Rights ruling in 2005, which basically made it very clear that if we are to comply with Article 5 of the European Convention on Human Rights, then when somebody is deprived of their liberty and is unable to give consent to that deprivation of liberty, then they must be accompanied. There must be accompanying safeguards to protect that person. And currently our Adults with Incapacity Act does not provide sufficient safeguards for that. We use guardianship as a stopgap, but it's not actually fulfilling the requirements of Article 5. The Mental Health Act obviously does comply with Article 5 mostly at the moment. That's all I want to say now. I think we'll hand over for questions. Thank you.
Hi, thank you so much for that. So, lots and lots of issues there to squeeze into quite a small time frame. I actually don't know if there's any questions have come through on the chat. Sorry. Yeah, I wonder if I could just ask for a bit of assistance with that iPad, which doesn't seem to be switched on. But yeah, some of my thoughts were that when you're looking at mental health law, one of the challenges is how to get a fair and consistently applied system when individuals vary so much in their presentation. So we're dealing with young people, we've got adults suffering from mood disorder or psychosis, we've got patients with dementia. Their needs are different. Some sorts of incapacity are transient, some are probably permanent. And how do we plan for that and to help all those individuals with different needs to get their views across? Don't know if you have any.
Well, I think there is, I suppose you can argue that people's needs are different, but some of the ethical principles underlying them are the same. So part of it is how do you apply consistent ethical principles across different frameworks. And I think one of the challenges in COVID, for example, has been the way people in care homes have been treated, which is different from the way people in the community have been treated. And there's no ethical differences in them, it just happens that they're in a care home. So sometimes I think it is about actually standing back and looking at the ethical principles. But the issue about support for decision making, for example, I mean, you're absolutely right that there's a huge difference between perhaps somebody with dementia who may or may not have the chance before they develop severe dementia to set out what they want, and we need to do much more around advanced planning, which will be different from somebody with a severe learning disability who's perhaps never had the ability to kind of say what they want. So we need different forms of support. If we have a model of support for decision making, I think one of the important things to hold on to is support for decision making isn't a thing, it's a whole lot of things. It's an approach which says, we're moving away from an idea that you start with a capacity assessment, which is essentially, you've got capacity, do whatever the hell you like. You don't have capacity, we're going to decide what's best for you, towards something which is much more nuanced and graded. But that's incredibly difficult to fit into a legal framework, I have to concede.
Yeah, absolutely. And yeah, in my day job, I do spend quite a lot of time saying capacity for what decision?
Exactly.
Because it's not such a black and white thing, is it?
I think
Okay.
we're trying to get to a sort of position where what is actually needed in this situation? Do we actually have to do a capacity assessment? Do we actually have to restrict this person in order to meet that person's needs? And it's a sort of balancing act.
Yeah, and a balancing of the public's expectations, I suppose, and the way that we all tolerate risk of harm to ourselves as well.
Yes, absolutely.
Yeah. Okay. Right, I know we are short on time, and I'm having some trouble picking up on the comments here. There's quite a lot, actually. Oh my goodness, I don't know if we're going to get through them all.
We could maybe email people if there are particular questions
Yes,
people
yeah,
have.
happy to
Sorry,
answer.
we have to
I
press
think
buttons.
that would work really well, thank you, because
Yeah.
we should move on to the second part of the session now. But thank you both very much.